about gentle cesarean. Some of you in the room may have experienced the gentle cesarean at Memorial, and we are just so grateful that we have these wonderful practitioners who are able to offer such an experience for women. So,
thank you so much, Amanda. That's so nice of you to say, but it's because we have wonderful patients. We're very lucky. We're going to sit, I think, so we can sort of, and hopefully eventually, I mean, when we don't really need slides anymore, we might just come closer so we can all have a little bit more of a discussion in a circle rather than have us be presenting and all of you listening. But I'm Susanna McGee, and of course, my friend John Morton is here with me, and thanks again, Amanda and Christy, for inviting us. You can hit the next slide. I think I'll just probably point to you, Christy, so I don't have to stop. But we have some objectives for what we want to do today, and they include defining gentle cesarean, giving some case examples of that, because you'll find that it's defined differently in different hospitals or birthing centers. Also, to discuss a little bit of the physiology behind skin to skin. I feel like I'm preaching to the choir right now, since most of you probably all understand that, but we just want to have a little bit of a background in terms of the physiology and the medical side of that. And also discuss some of the methodology in implementing a gentle cesarean, because it's actually tougher than it sounds, even though it seems so simple. There's lots of inertia in medicine, and these things are kind of difficult to change people's perceptions about, but we've done a pretty good job at our small community hospital, so we'll talk about what we did for that. So I am a mother of 3, and I was lucky enough to have 3 gentle vaginal births. My first one, I think I was at the hospital for 20 minutes before she was born. I lived very close to Memorial, and I delivered all my children at Memorial. I am an assistant professor of family medicine at Memorial Hospital, Brown University. So I teach medical students, I teach residents. I'm responsible for all the family medicine resident education about obstetrics and neonatal care. And I also run a fellowship in maternal child health. So I'm training family doctors to do cesarean and to do high-risk obstetrics for people, for instance, with hypertension, diabetes, other chronic medical conditions, so that they don't have to necessarily seek specialist care for the entire pregnancy. They might need a consult, but they don't have to necessarily transfer care to a large institution. And also, I'm the only family physician right now in Rhode Island doing cesarean, so it's kind of unfortunate because there's a number of them trained, and due to malpractice insurance costs, they've had to drop the procedure because it just makes the malpractice insurance rise so much, unfortunately. So I'm going to hand it over. That's a little bit about me. Annabella, Fiona, and Lila, 3 girls who are great. So, Dr. Morton,
You should see the McGee's in action.
I think I talk fast.
It's always lively.
It's a little scary.
I'm John Morton. I am I'm Sue's partner in many respects.
It's my work husband.
I've been a practicing obstetrician gynecologist in Rhode Island for the past 8 years now. Years. I'm the uncle to 24 nieces, nephews, great nieces, and great nephews. So I feel like I have to tell a story about how, someone who doesn't look that old can have that many nieces and nephews. My mom had me when she was 45, and I was the last of 4 children. And there are 15, 18, 21 years that separated me and my siblings. So if you can imagine what it was like some 40 years ago to be 45 and try to have a child, there's a lot of like, oh, I think you're going to die in childbirth. This is a really scary thing. My mom was very sort of determined and persevered and had a very smooth, uneventful vaginal delivery. And all of my sister and brother's children all have children. And so I have grown up in a family where I've taken care of lots of little ones and lived through pregnancies. It's an interesting growing up experience. Among the many things that I do at the hospital, I am advisory faculty for the maternal child health fellowship program that Sue described. I too work with residents and medical students teaching obstetrics to family medicine residents at well, outside the hospital, some of my sort of community work includes working for Planned Parenthood, where I recently served as the chair of the board for Planned Parenthood Rhode Island. Many of you know Planned Parenthood Rhode Island, they recently merged with Planned Parenthood Connecticut. It's now Planned Parenthood Southern Connecticut. So, it's very nice to be here. And certainly an assistant clinical faculty at Brown as well.
We bring that up for a very important reason, and I think it's because we're teachers, and I think teachers communicate with their patients in a different way, perhaps, number one, and also because we want to sort of get out there to the pregnant folks in Rhode Island the importance of allowing trainees to be in your experiences. If we don't let trainees see the way it could be done in a gentle cesarean or a gentle vaginal birth, no, they're not going to know that this option is out there, and if they grow up seeing it in their training, they're going to grow up expecting it. And so I think that that's why we bring it up, really, more than anything, so you know a little bit about our background. Go ahead. Thanks, Christine. Another important introduction is that we, of course, agree with ICAN's philosophy. I was a bit of a blog hog last night, reading all these very interesting things on sites associated with ICAN and not associated with ICAN about gentle cesarean, saying, you know, things like, gosh, you know, if we talk about gentle cesarean and let these doctors do it gently, they're going to think that this is the right way to deliver all babies. And that was horrifying to me. You know, we, of course, believe cesarean should be reserved for those who require a cesarean, and don't think just because we're doing it in as gentle a manner as possible that it should be the preferred way to birth a baby. It's an option for people who require it to have it this way. And so I wanted to bring that up because I saw that over and over again, and I was just thinking, gosh, I feel like a monster right now that people could be walking around thinking this on the street, that this is what people who do cesarean section are thinking. And so if there are people out there doing cesarean who think that way, I don't think they're common, actually. Really, I don't. But I also think that's sort of taking it to the other extreme, and it's probably very unlikely. I don't certainly think at Memorial Hospital we're going to be slipping in that direction in any way. We just want to improve the cesarean section experience for those who require it. So, let me go ahead and the next one. And so, John and I can both speak to this, but I think the definition differs in various birthing centers. It could be just skin to skin in some places. Okay, after the delivery of a baby and during cesarean, the baby will be brought and placed on mom's chest rather than placed, you know, on a warmer, which I like to call the cooler, because we all know that this is the warmest place for baby, you know, to the side where mom is craning her neck to try to see, and dad or a doula or anyone else present is, you know, can't help but block her vision, and it's very difficult. It can also be, to the other extreme, the birth visualization through gentle propping of the mom. I have really just started to read about this. It's not something we're currently doing at Memorial, but we're definitely going to talk to people about this, because it's really exciting, the idea of propping mom 30 to 45 degrees so she can actually visualize her baby being delivered. A calm environment. Some people could call a gentle cesarean just a calm environment where the surgeons aren't talking about Saturday's game or their own families or, remember the last time we did this and this happened? I mean, this is a really important experience for a mom and her family, and we definitely understand that. It could mean delayed cord clamping, so 30 seconds, a minute, 2 minutes, when it's time, when people decide they need to clamp the cord, you know, when it stops pulsating. There's lots of definitions of delayed cord clamping, but that it could just mean that in certain birthing centers. And also the presence of multiple support persons. So this is a really new, exciting thing at Memorial. It used to be that only one person was allowed in the room. That could be dad, that could be another support person, the partner of the patient. But now doulas are present, you know, for these, which is really exciting. If somebody wants a doula, they come into the OR, and lots of the doulas in the room have experienced that, so I'm excited about it.
Yeah, I would say that I was curious about the propping thing after doing some reading and stuff, so I went to the hospital today and I checked out the bed. And we have a really, really old OR bed, and unfortunately it doesn't prop. But we've talked about actually having mirrors suspended from the lights.
Right.
There used to be, when we had these old lights in the operating room, there used to be this reflection that you could look into the light and see what was going on.
If
now
mom wanted to, she could watch the whole thing.
But now with these new lights, you can't actually do that. So we're
But we can
thinking,
see better. Which is if you want to see what we're doing.
in light, we lost the reflection.
We lost the reflection.
So we're actually thinking about putting a mirror there so that if someone wanted to watch what was going on, it's probably the way.
We've had lots of thoughts, and maybe we can talk about it as a group afterwards, but like, you know, there's probably bolster pillows or wedge pillows we could use for that scenario too that could be easily placed and removed. There's, you know, that could be the job of the volunteer doula in the room, or the doula that's being paid to participate by that mom to be there. That's another possibility. This is a picture of our hospital. You want to talk a little bit about Memorial Hospital, John? And then you can just look past.
Oh, well, sorry.
Just want to show people what it looks like.
So, you know, every hospital has its own style, and these are just some of the things that we think is characteristic of Memorial. We can certainly control the environment, and that has to do with people in the room understanding sort of the environment we have. People want to bring music. We have played music. We listen to 82 reggae songs.
Oh my goodness.
Our last delivery together. But it creates a different atmosphere, certainly. Each member of the OR team is really focused on the experience of the mom and the experience of the baby, and the experience of the family present in that room, family and support people in that room. Certainly, as we talked about before, more than one person can be there to support mom and baby. The way cord clamping is pretty routine at Memorial, and so the dynamics of that are once a delivery happens, the baby's kind of sitting on mom's lap, and the way cord clamping is going on as the baby's being dried, and there's sort of a brief assessment to make sure the baby is okay to go on. We certainly do encourage immediate breastfeeding, so we've had moms breastfeed even before surgery was done, which was pretty cool, like that. And really creating an environment where there isn't necessarily separation of that baby from the family, so that family unit can stay together in the room.
So even, when the mom's being transported from the operating room bed to her actual bed that's going to be in her room, which will then be wheeled to her postpartum room, mom's holding the baby on her chest. We would say hug yourself as you're transported by the team to the bed. Well, hug your baby, and then you're hugging yourself while you hug your baby. But if your hands are held here, you're also not at risk to get tangled up in the cords and the various. It's actually helpful to have the baby there because then mom won't move her hands because she's not going to let go of her baby. So we're not perfect though at Memorial. I don't want to make it sound like that. This is something that we've been doing for about a year, and we're not doing it for every cesarean. It's still an opt-in versus an opt-out procedure. So for folks who we know are interested in this, those are the folks we bring it up as a possibility rather than having this be the routine. And that's something that's starting to change, by the way. I don't want you to think that that's going to stay like that forever. But that's really what it currently is. It's people who are opting into this rather than opting out. We do have women, at our hospital who birth there who will say things like, I really don't want to touch my baby until it's dried off. Like that I don't want it to be all wet and slimy. And, that takes a lot of time to sit down and say, let me tell you why it's important to hold your baby when she or he is all wet and slimy. But, sometimes we can't convince people of that. And I don't want to force anyone into this. I certainly want this to be something that they want. The other is, the other thing I just wanted to say out loud is that there are times where we do an emergent cesarean section, which is a very different procedure and a very rare procedure. I also want to make that clear. It's very rare to have a true emergent cesarean section, but there are times, in the next slide we'll talk about why this would be difficult to do and those things. The ACOG definition of an emergent cesarean is actually decision to have a cesarean section to incision as 30 minutes. And that might sound like a long time to you, but if you're in a labor room, having that patient be transported down a hallway, being prepped, having a catheter placed, having anesthesia, if they don't have anesthesia yet, 30 minutes is a long time to do that and then do the actual procedure. In fact, when John and I do emergent cesareans together, which luckily is a rare thing that we have to do, we have the baby out within 2 minutes of the incision. When we're talking about gentle cesarean, 10, 12, 15, we're chatting with the mom, we're making sure the partner wants to see, he or she can see. It's a very different procedure than having to do something urgently. And ACOG's definition of an emergent cesarean, the things that I want to talk about the reason why I want to talk about it is that very commonly the neonate will need a resuscitation when it's truly an emergent thing. And that is really difficult to do on mom's chest and frankly impossible. So that's a time when you need to have the space on a warmer to actually do the procedures there.